Testing 1, 2, 3, 4. Mary had a little lamb. Good morning. It's May 25th, Saturday. Setting up for the May Ask Me Anything Multiple Sclerosis live stream. This is Aaron Boster getting set up. Waiting for folks to join us online. Testing 1, 2, 3, 4. Mary had a little lamb. Hey, Carrie Perry, how you doing? Heidi Ho from a small town in Indiana. Welcome. You're the first to join us. Yasmin's in the house. Welcome. Pink Meadows, always here on time. Bluthton here, one of our amazing moderators. Thank you for being here, everyone. Good morning. We're getting ready to kick off our May Ask Me Anything live stream. This is Aaron Boster. Delighted to be talking with everyone today. Mish Woon, hello, howdy, hi. Lisa is here from Australia representing what's going on down under. Alexis is in the house. As you guys jump online, of course, please tell me where you're jumping on from. I love to go back through the live stream after it ends and see where this growing global online village has amassed. We've got Chillicothe representing. Athens, Greece is in the house. Hello, Gus. Howdy from Indiana. Lynn joins us. British Columbia, Canada is in the house with Lainey. Hello, this is fantastic. Jersey Shore is represented. South Dakota's in the house. Hello, Natalie Walker. Thank you very much. Alexis is from Michigan. Nate, hello, how are you? Cobra King is in the house. Joe Ellen has joined us from Tucson, Arizona. This is phenomenal. Ron in Delaware, welcome, welcome. Kyle Springfield is representing. Westerville, Ohio is in the house, as is Las Vegas. Alabama representing. We've got another moderator that just jumped online. This is Angela from Chillicothe. Thank you for being here to help out. Manchester, UK. This is phenomenal. As always, we will go live at the top of the hour, starting our Ask Me Anything live stream at exactly 11 a.m. We've got 30 short minutes before we kick it off, giving everyone an opportunity to grab a beverage for the MS Water Challenge, grab some coffee, get comfortable, take a bio break, and get ready to rock and roll at the top of the hour. Melbourne, Australia representing. Calgary is in the house. That's phenomenal. Greenville, South Carolina. Welcome, Linda. Jeffrey's in the house. This is fantastic. North Carolina representing. Ontario, Canada. Ottawa is here. This is phenomenal. Rob says, go blue. I'm in Ohio. I can't say that too loud or bad things can happen. Everybody, Charles Boster, my dad, is online. Hey, Dad, great to see you this morning. Carla from Kansas says, hello, howdy, hi. And Newfoundland, Canada representing. That's on my bucket list for sure. Devon, UK. Hello, Elizabeth. Welcome for being here. Wow, Lucas from Croatia. That's phenomenal. Rio de Janeiro is in the house, as is representation from Colombia. That's fantastic. I've visited Colombia twice, some of the best food I've ever eaten. We've got New Jamshire in the house. Maureen is here. Go Bucks. Okay, there we go, Jenny B. Welcome, everyone. Welcome, welcome. This is Aaron Boster, broadcasting live from sunny Ohio, and it truly is beautiful and sunny out today. I am excited to kick off an Ask Me Anything Multiple Sclerosis. This is our May live stream. There's already 92 of you that have jumped online. Arthur is representing Boston today. I've got Raj from India. Where in India do you hail from, Raj? Put it in the chat. Shay is in the house. What's up, Miss Wilkinson? Damien representing. Damien, no worries. We're going to, of course, have a live replay. You can watch it later on. That's not a problem. Howdy, Texas representing. Great to see you, David and Jimmy Fox. We will talk about BTK inhibitors, Jimmy, no sweat. Once we go live at the top of the hour, that is definitely something to talk about. Thank you, Raj. India represented more than once today. That's phenomenal. Now, Gus, we're going to hold our questions until the top of the hour at 11 o'clock when we go live. Dublin, Ireland is in the house. One of the most amazing cities in all of Europe. Dublin is an amazing time. Bucharest, wow, Romania is representing. 61 Roxy, thank you for being here. Idaho is representing. Susan, thank you for joining us. As you guys jump on live, please share where you're coming in from. It's amazing to see where this global growing online community has amassed from. There's 94 of you that are here already. I have a couple fun things planned for us today. Texas is representing. Great to see you guys. UK London, what's going on? Super Brog, that's a really, really nice thing to say. Thank you for saying that. Jordan is in the house. That's phenomenal. Thank you for being here. January Sunshine representing Ohio, OH. Now everyone in Ohio just screamed IO in their head. That's how we do it here. Becky Rogers, thank you for joining us from North Carolina, a beautiful state. There's 95 of you that have jumped online. I'm in the throes of getting everything set up for you today. Remember that we'll go live at the top of the hour at 11 o'clock sharp. I'll take your questions live. Ask me anything multiple sclerosis. We've got Norfolk, UK in the house. Thank you very, very much for being here. Stay tuned. I'm going to mute my mic for a moment while I get things set up in the background. Welcome, welcome, welcome. Welcome everyone, Aaron Boster here. We're going to go live in about 20 short minutes at the top of the hour. Karen Tweed has joined us from Winnipeg. Karen, thank you for being here. Georgia representing. This is fantastic seeing everyone get together for this May Ask Me Anything live stream. Rob, thank you for being here. We'll address that question shortly. Queen of Infamy, that's a great handle. Good morning to you. Washington Courthouse is representing here in Central Ohio. Wonderful. As you jump online, make sure that you share where you're coming in from. I love to go back and see where this global growing online village has amassed. I'm going to be taking your questions live. Ask Me Anything Multiple Sclerosis. This is Aaron Boster from the Boster Center for MS. Thank you for joining. While we're getting geared up, let me post a couple of key links that might be of interest to some of the people listening in. Five-minute break at in the chat. I'm throwing in a link to the Boster Center Boster Corner. This is a monthly informational newsletter. Comes out to your email if you sign up. It's completely free. Kind of tells you the latest and greatest at the Boster Center for MS, what research is going on, and anytime that I'm going to be going live. So if you'd like a schedule of all of our live streaming events, feel free to click that link and you can sign up if you'd like and be informed each and every time that we're getting ready to go live. Upstate New York representing. Joe, thank you for being here. Welcome, everyone. Annette from Lexington Park, Maryland. Welcome. There's 92 of you that have amassed. That is phenomenal. Thank you for being here today. If you haven't clicked the link yet, go ahead and click on that Boster Corner link. We'll give you an update to anything new, exciting in the world of MS, and particularly research at the Boster Center for MS. It'll tell you when we go live, so you won't miss any of our live streams. Istanbul representing. Dominic, thank you for being here. We've got Waterford, Virginia representing. Stacy, thank you for being here. Carol's asking for information on cannabis. Happy to talk about that today. Gus, that's a great observation. Suzanne, that's very, very nice of you to say. Thank you for that. Michigan representing. Bipolar, great handle. Loving that. Good morning, Kim. Phil, thanks for the suggestion. If you guys like what we're about to do, go ahead and hit that like button. It lets the YouTube algorithm know that you dig the content and helps push this out so more families impacted by MS can benefit. Mississippi representing. Thank you for being here, Amanda. Wonderful to see you this morning. Virginia, Kesimpta is a high-efficacy medicine, wonderful drug. It's in the class of B-cell depleters, and there is a literature on some improvement on some of these high-efficacy medicines. Look at those hearts coming through. Thank you very much for the hearts. That's another way to tell the YouTube algorithm that you dig what we're doing. Crestview is online. Rhonda's here from Florida. Thank you for being here. What's going on, Los? Thank you for the hello, howdy, hi. We've got Australia in the house. Thank you for the hearts, everyone. Big love going out. We're going to go live here in 15 short minutes. We've got the Bahamas in the house. K-Roll. Most of us online now are jealous of you. That's awesome. Pennsylvania representing. Thank you for being here. What's next, Deidre? Thank you for the hearts. Go ahead and give this a like if you dig what we're doing. Tennessee is in the house. Wonderful to see you here, Phil. Thank you very, very much. January, that's a really good point. Queen of Infamy is in the house. Thank you for being here, Jess, and welcome. If you haven't already, click the link to the Boster Corner. Get updates to all that's new at the Boster Center. And importantly, gives you a list of every time that we go live. I'm so honored that you guys have jumped online with me. There's 103 of you. We've got Lucas from Germany. Thank you for being here so much. We've got Vienna, Austria in the house. What's up, team? I spent a couple amazing weeks in Austria. That's where I learned about wine spritzers. There's nothing more refreshing when it's hot outside. 109 of you have jumped online. We've got Kansas in the house. What's going on, Andrew? Thank you for being here. Linda White, welcome, welcome, welcome. Thank you very much for being here. This is phenomenal. I am so excited to go live here in 15 short minutes. We've got Christina, Virginia representing. Thank you for being here. Welcome. Make yourself comfy, cozy. Long Island in the house. Imp Mac, that's a great name. Good morning to you. 113 of you have jumped online. I can't believe that. That's phenomenal. K-Roll, hello, hello. Raj, thank you for sharing. Yeah, they really are perfect, aren't they? Bienvenue. Julien, merci d'être venu. Ça fait longtemps, mais j'habitais en France, au nord de la France, à Nantes. J'étais un étudiant d'échange. C'était juste après le lycée, avant que j'ai commencé la fac. J'habitais avec une famille d'accueil, au fait, 2 familles d'accueil. Merci bien pour être venu ici Oh, Chris, that's super nice of you. Thank you so much. Yep, I know you're a neurologist. Great human being. You're in good hands. Hard Drive USA reminding you to hit that like button. Show the YouTube algorithm that you love this content and help push it out so more families impacted by MS can benefit. We've got South Dakota representing. Luca, that is a reasonable discussion I would love to have with you today. Welcome, Nikki. Welcome, London. It is great for you to be here with us. Thank you for joining us. This is phenomenal. I'm so excited as you guys jump online. Welcome, Kat from St. Louis, representing the Midwest. Alexis, that is a very good point, something worthwhile talking about. UK is representing. That's phenomenal with 118 of you that have already jumped online. If you haven't yet, feel free to click that link for the Boster Corner. You'll get updates once a month about what's new, fresh, and exciting at the Boster Center for Multiple Sclerosis, including every time we go on live. No Greek, I'm afraid, Gus. I can do English and I can stumble through a little bit of French. Why? That's a great question. Happy to talk about high-dose vitamin D once we start taking questions at the top of the hour in 12 short minutes. Philly's representing what's going on. David Barnes, thank you for joining us. Jennifer, that is a reasonable thing to talk about, the risk-benefit of taking a medication. Jennifer Reed is in the house. Where in Arizona do you hail from, Jennifer? Just out of curiosity. Poland is here. Thank you so much for being here. I spent a weekend in Warsaw doing some work, and it was an amazing opportunity to walk around a very historic city. New Mexico is in the house. What's going on? Autumn in Albuquerque. Thank you for joining us today. This is the Ask Me Anything live stream, the May Ask Me Anything live stream. For some time now, once a month, I jump online so that I can get together with you guys and kibitz and talk and answer your questions live. It's an awesome opportunity for me to interact, and it fills me with energy. So thank you so much for being here. Larry representing Ohio, Hamilton, Ohio. Australia is in the house. Thank you for being here. Hello from Germany, Smoky Waters. Thank you for joining us. Washington State representing Kettle Haven. Howdy hi. Christine is asking about MS Hug. Soren from Michigan. What's going on? Go Blue. Sandy asks, how does extreme heat affect MS? That is absolutely worthwhile talking about. What's up, Marie? Thank you for being here. Oh, you're in the Pyrenees. But dis donc, ça c'est génial. C'est très beau là-bas. Hello in Colorado. DMO has joined us. Thank you for being here. Susan representing the UK. Brighton, England's in the house. What's going on, Roman? ATL is in the house. Atlanta, Georgia. Beautiful down there. Phil, there you go, buddy. Imp Mac is in the house. We've got Marco Island representing Florida. I'm a little jelly. England is representing Waka Wacky Paranormal. Great name. Ontario, Canada is in the house. Great question about hormone replacement therapy. Czech Republic representing. Thank you for being here. D. Brown is in the house. Shannon, British Columbia. I have wanted to visit British Columbia for some time. Susan wants to know why cold weather worsens spasticity. Excellent question. We'll go live at the top of the hour in 10 short minutes. India representing. Carolyn asks about chronic yeast infections. Not a fun topic, but very important to talk about. Happy to tackle that today. Thank you, Shannon. I would love to. There's 137 of you that have jumped online. That warms my heart. Thank you for being here today. If you haven't yet signed up for the Boster Corner, feel free to click that link. In fact, I'll post it in the chat so it's fresh. Click that link and you'll be signed up for our monthly newsletter from the Boster Center for Multiple Sclerosis, where everything new and exciting is listed out for you, including when we go live, so you never miss a future live stream. We're about to kick off in 9 short minutes the May Ask Me Anything live stream. Get your water at the ready, grab a coffee if you're inclined, get yourself comfy and cozy. We will get started here in 9 short minutes. I want to thank all of the wonderful moderators that are here, helping keep everything smooth and easy breezy. I'm very much looking forward to answering your questions live in 9 short minutes. I'll be back in moments. I'm going to mute my mic while I get things set up in the background. Thank you for being here. Wowzers! I stepped away for a short minute. There's already 143 people that have jumped online. Thank you, everyone. As you jump online, make sure you share where you're jumping on from as we grow this global, growing online community and village. It's amazing. Thank you for joining me today. This is Aaron Boster, excited to kick off the May live stream, Ask Me Anything Multiple Sclerosis. We're going to start taking your questions live at the top of the hour in 7 short minutes. Thank you for those hearts, whoever you were. Those hearts let the YouTube algorithm know that you dig this content and help push it out so more families impacted by MS can benefit. You can also jump off the live stream, give it a thumbs up, and jump right back on. That's another way of teaching the YouTube algorithm that what we're doing is awesome. Robert Wilhelm is in the house. Hello, good sir. Thank you for joining me today. Delighted to see you here. I hope you and yours are doing well. What's going on, Mama Bear? Thank you for being here. Chris Champion is in the house. Manchester, England represented. Thank you for being here. We've got questions coming in about migraines and MS. Alabama, what's going on? Hello from Sweden, Stefan. Thank you for joining us. That is phenomenal. Soren's asking about tremor. I've treated some very challenging tremors just this week. Happy to talk about that. Mr. John Poling, representing Dayton, Ohio. Hello, good sir. Thank you for being here with us today. We're going to be going live in just 5 short minutes. As we get closer, you know how we do it. We're going to ask you to flame up the chat. Don't do it yet, but in a few short minutes, I'm hopeful that we can completely flame up the chat as we jump online. Queen of Infamy, that is an awesome handle. Linda, thank you for the question. I'll tackle that in a little bit. Renee, welcome. Utah representing. Delighted to see you here. Throw those hearts out, guys. There's 149 of you ready to rock and roll. Anthony's in the house asking about lion's mane, a fascinating mushroom with a lot of really interesting elements to it. Tell the Truth is asking about IVIG. What's going on in Texas? Mexico City representing. Thank you for being here. This is phenomenal. Jenny B's asking about CRPS. We've got questions coming in about epilepsy. We've got questions coming in about spasms. This is going to be a rockin' live stream. Gosh, we already have 149 of you that have jumped online. That is phenomenal. Boulder, Colorado's in the house. Theodore, I am super jealous. You live in one of the most beautiful places on earth. We're about to get started. Get yourself comfy and cozy. Seattle is in the house. Thank you, Jam Master Mike. That's a great name, by the way. I am delighted for you to be here with us today. 4 minutes. 4 minutes and counting. T-4 until we go live. Osteoporosis due to steroids. Lots of discussion about that to be had. Live one to live. Asking about autoimmune encephalitis, another autoimmune condition obviously affecting the brain. We'll try to get to that question, Queen of Infamy. In the Canary Islands, originally from Italy. Fantastic, Martina. Thank you for joining us. One of my closest friends grew up in the Canary Islands. I've only seen pictures, but gosh, it looks beautiful. Stacy, thank you for being here. We've got 3 minutes. Get your flames ready, guys. With 2 minutes to go, you know what we do here. We're going to flame up the chat. 3 minutes until we go live. 162 people. I don't know that we've ever had this many people before we jump online. That is phenomenal. Questions about birth control coming in. Rather important. Southern California is in the house. Julie, thank you for being here. Questions coming in about Ty Sabri from England. Thank you for being here today. Erica, that is a really great topic. Now look, guys, we have only 2 minutes until we go live. Let's flame up the chat. You know how we do it. Throw flames in the chat. The goal is to get the entire chat flamed up. We want to see flames from the top to the bottom of the chat as we get ready to rock and roll with only 2 short minutes. Carol's got the right idea. Robert Wilhelm is helping out. Exactly, guys. Throw flames in the chat. We're going to get rocking and rolling. Robert, thank you for leading the way. Karen Tweed's got the right idea. Kat and Susan Brown are showing love with flames. We have literally under 2 minutes until we go live. Linda White's got the right idea. Flame up the chat, guys. Show love. Let's tell the YouTube algorithm that we are pumped to be here today. Mama Bear is in the house with flames. We got Jenna in the house with flames. Kelly's showing flames. Stefan's got flames in the house. Exactly what I want to see. This is Aaron Boster from the Boster Center for Multiple Sclerosis. This is our live stream, the May version, Ask Me Anything MS, with 170 people online. Darren's got flames. Alexis has got flames. Kat's got flames. Exactly what we want to see. We have literally under 1 minute until we go live. I am pumped, and I hope you are too. Jennifer Murray's got the right idea. KL Burke showing flames in the house. Jazz and Blues is flamey, flamey. This is super. Julie's got flames. Deanna's got flames. Rum has got flames. Alexis, that is exactly what I want to see. Counting down in under 60 seconds. We're about to rock and roll. Danny Quinn's got the right idea. Jennifer Murray's in the house with lots of flames. We've got Mexico City showing flames and love. This is phenomenal. Seconds before we kick it off for the May Ask Me Anything live stream. Shay, thank you for the love. Keep showing flames. You know how we do it. Renee, this is phenomenal. 174 of you are here. We are ready to rock and roll and take your questions live. Imp Mac is showing flames. Eric, I love the brains, and it's time. Howdy, hi, everyone. Hello, Aaron Boster here. I am so excited to be here with you today. When I started the Boster Center, I committed to jumping online once a month so that I can connect with all of you. It gives me an awesome opportunity to connect with this global growing online village and to answer your questions live. I want to thank you guys for jumping on today. It looks like I need to get a couple things popped up in the chat. We're going to show the viewer count, which is at 187. Thank you, thank you, thank you. When I started this YouTube channel way back in 2015, I never ever thought about a community forming, and that is exactly what this is. This is a virtual community. It's very near and dear to my heart. Thank you for joining me today. This is our May monthly live stream. I'm excited to take your questions live. I have a couple fun things planned for you. As you jump online, please share where you're jumping on from. Also, as we share questions, please make sure to make the questions generalizable, because I can't diagnose you, I can't treat you over the interwebs. And so ask the question in a way that everyone can benefit. Bluthden, one of our amazing moderators and OGs of this channel, has just thrown up a question. I read that functional neurological disorder and MS can often be misdiagnosed for one another. How are they different? Heard it's like a hardware and a software issue. That's a really great question. So there's 200 of you online listening to this answer. Functional neurological disorder is a tricky wicket, and it's true that multiple sclerosis can mimic lots and lots of things. If somebody asks the question, could multiple sclerosis cause blank? The answer is almost always yes. Why? MS affects the supercomputer that runs the body and the superhighway, the spinal cord that takes the information from the computer back down to your feet and back up. And so when you are dealing with myriad neurological symptoms, MS is going to be in the diagnosis. Now, functional neurological disorder is a problem which can mimic a lot of different things, and in many ways, it's what we call in medicine a diagnosis of exclusion. You can only come to that conclusion when you've crossed everything off your list. And so now you can start to see how there's two conditions which are challenging to diagnose, and one might get flipped around for the other. One of the big advantages in my mind in diagnosing MS is that it's not based on a feeling, it's not based on an opinion, it's based on hard facts. Taking a careful neurological history, buttressing that history with a neurological examination, sometimes what I call the MS Olympics, is really intended to identify objective deficits on exam which support the story. We use neuroimaging very, very heavily when diagnosing MS, and the changes that we see on the brain and spinal cord in multiple sclerosis, we would not expect to see in a functional neurological disorder. Also, 90% of people impacted by MS will have abnormal findings on their spinal fluid, and we would not expect to see that when you're dealing with functional neurological disorder. Bluthden, as always, that is a great question. Thank you for asking it. We're going to jump on to Crafty Corner, who asks, are thoracic lesions the same as spinal lesions? Yes. So the spinal cord, which connects to the base of your brain all the way down to your tushy, is a long conduit. I like to call it the superhighway. And it takes information from the brain down to the feet and back up. And all along the spinal cord, nerves come off, which serve the arms, the chest, the legs, etc. And we neurologists and radiologists like to divide the spinal cord for easy talkability and easy study. We oftentimes talk about the spinal cord in your neck as being the cervical spinal cord. The spinal cord in your chest is called the thoracic spinal cord. And the spinal cord below there, down in the down there's area, that's the lumbar spine. Now, in reality, it's all just one long thing, and we segment it. And so when someone talks about a spinal cord lesion, it could be anywhere in the spine. Now, in the setting of multiple sclerosis, spinal cord lesions are most often seen in the cervical spine. Second most would be in the thoracic spine, and we don't see too many lesions in the lumbar spine. Thank you for asking that question. I am says, is this still live? Yes, I am live. Hello, howdy, hi, and thank you for joining us, I am. Let's take a look for some other questions. So Vivian Cook asks a question. Can I take a statin for high cholesterol when on Ocrevus? So the obvious medical disclaimer, Vivian, is that I don't have any information about you, so I can't give you an answer for you, but I can answer generally. And obviously this is something that you're going to want to talk to your clinician about. So multiple sclerosis will not kill you. In the modern era with treatment, we expect the life expectancy to be normal, which is awesome. Cardiovascular risk factors can cause heart attacks and strokes, and that can kill you. And it's very, very important, in my medical opinion, that we treat cardiovascular risk factors when we have them. Things like avoiding smoking, things like avoiding morbid obesity, things like treating high blood pressure, and things like dealing with high cholesterol. And so if you have a high cholesterol, that is a concern for cardiovascular risk factors, increasing your risk of stroke and increasing your risk of heart attack. And so with the supervision of your doctor, you can be put on a statin medication. Is there a concern having a statin and Ocrevus? Absolutely not. I have many, many patients who have MS and high cholesterol, and they're on both, which is awesome. I take a statin to lower my cholesterol. Thanks, Mom and Dad. and that lowers my risk of stroke and heart attack. We don't want to ever assume that someone is an MS. That doesn't exist. People are human beings, and they have lots of different things going on. Sometimes nature's too generous, and you can have multiple sclerosis and high cholesterol. In my experience, we can treat both very safely. That was an awesome question. Kat has a question. She asks, or he asks, can optic neuritis or anything else about MS cause cataracts at an early age? So cataracts are not associated with the autoimmune condition multiple sclerosis, but again, sometimes nature is too generous. There are certain medications which might increase risk for cataract, and the good news is if you have a cataract, then you can have it treated. Ophthalmologists are amazing at taking those things out and regaining vision. All right, let's take a look for another question. David shares that the medullary lesion that he has is under control using Tysabri. That's great to hear. Vivian, you are more than welcome. So Y has asked a question, why? About a protocol which is very popular in the MS circles on the internet, which involves taking ultra-high doses of vitamin D. So let's spend a few minutes and talk about vitamin D. So first of all, where do we get vitamin D? Well, there's really two ways to get vitamin D. One is going out in the sun. When the sun hits your skin, there's a reaction in your skin, and you make vitamin D3, cholecalciferol. Vitamin D3 is best absorbed biologically in the body. And if you go out in full sun and shirtless, or maybe just in a brassiere, for 15 minutes, you'll absorb 5,000 international units of D3, which is really interesting because here in Ohio, that's typically the dose that I ask my patients to take. The problem is, here in Ohio at least, halfway through the year, if you go out for 15 minutes, you're going to get frostbite on very unpleasant areas. So a different way of getting vitamin D is by things that you eat. And so a couple foods are very high in vitamin D. For example, egg yolks are really packed with vitamin D. For example, fatty fish like salmon or tuna is packed full of vitamin D. Now here's the issue. A 3.5 ounce, so that's not big, 3.5 ounce portion of salmon, like a typical dinner size plate salmon, gives you 500 international units. And so you would have to eat 10 of those in order to get your daily allowance of vitamin D. That is a hard thing to try to do. And so most of the time here in Ohio, when I check vitamin D levels, they are very, very low because we don't have a lot of sun out there half the year. And so I recommend that people take a vitamin D supplement. Now, when you go to the supplement store, they have vitamin D2 and they have vitamin D3. Vitamin D3 is better absorbed in the human body, and so that's always what I'm asking my patients to take. As it relates to multiple sclerosis, it's a very interesting literature. There is no objective 100% guaranteed proof that raising vitamin D levels slows the disease. And yet, I want all my patients to take it. Why? Because there's a lot of associations which are very, very compelling, that in patients with MS, high levels of vitamin D correlate with better outcomes. High levels of vitamin D correlate with less MS attacks, with less MS lesions, and in some cases with slower progression of disability. Now, there's a lot of nerd fighting amongst neurologists about whether it's caused by the vitamin D or not, but here's the dealio. In my mind, it's safe to supplement vitamin D as long as we keep that level below 100. That's my cutoff for the laboratory, the vitamin D25OH level, which is an easy blood test to obtain. And so I think the better part of valor is to drive the vitamin D up because I believe that the data is supportive, and I think that for a vitamin, it can make a really big difference in multiple sclerosis. Thank you for asking that question. Let's take another question. So Cindy asks a question, which has actually been asked for quite some time in the medical literature. She says, can a traumatic brain injury lead to MS? Aphasia and migraines daily, spots on my MRI. And so the data is not very robust. There are a couple studies that look at trauma, and it does not appear that a closed head injury is going to cause multiple sclerosis. There is a very interesting debate. Actually, one of the forefathers of multiple sclerosis who helped develop the Poser criteria, Charlie Poser, wrote a couple papers on the topic. As I've reviewed the data, I cannot conclude that a traumatic brain injury can cause multiple sclerosis. I will share with you that a traumatic brain injury can cause a lot of neurological features which can mimic MS. A traumatic brain injury can cause contusions on the brain, which cause white spots, which can be confusing with multiple sclerosis. So Linda asks a great question. I want to grab this one before it leaves the screen. Linda White says, hey, which is better in efficacy, Mavenclad or Zeposia? And the first proper comment is we don't know. Why don't we know? Because there's never been a side-by-side, head-to-head Pepsi-Coke challenge of Mavenclad and Zeposia. So the real answer is we can't say. Now, what we can try to do, which we're not supposed to statistically, but we sometimes do it anyways, is we can try to look at the data for Zeposia and look at the data for Mavenclad and try to get a gestalt. It's my opinion that Mavenclad is superior, and I'm going to share why I say that. You have to follow my logic. There is a really cool statistical measure which is called propensity-weighted matching, where you can take a big population of people on one drug and a big population of people on another drug and do some fancy pants statistics which allow you to try to do a comparison. Now that's about as close as statistically we're going to get. And whereas Mavenclad and Zeposia have not been compared, Mavenclad and the parent compound, Gilenya, have been compared. And in this propensity-weighted matching study that was done, it was demonstrated that Mavenclad patients had less attacks, had less time to their first attack, and it looked like it was a better drug. Now, I really am kind of stretching and twisting statistics to try to answer that question, and at the end of the day, that's just my opinion, which doesn't make me right. It just makes me really opinionated. Do I think people on Zeposia are going to do poorly? No. Do I think everyone should switch to Mavenclad? No. Do we really know the answer? No, but as I look at the data, that's my impression, and thank you for asking that question. All right, let's see here. What's another question coming at us? Let me check this question out. Now, Smoky Waters says, how does inflammation get in the brain? Can infection of the skin cause inflammation? So inflammation is a term that we kind of throw out all over the place. And if you get cut and your cut gets red and swollen, that's inflamed. If you punch me in my face and my face gets all puffy, my cheek is inflamed. And multiple sclerosis is a different kind of inflammation. What's happening in the setting of MS is your immune system is misbehaving. It's acting naughty. And it's identified your brain and spinal cord as a foreign invader, like a viral attack. And when the immune cells are doing their tour of duty, and they're going through the central compartment and they see your brain, they think it's looking at a virus, and they attack it, trying to kill what they think is a virus mistakenly. And they use inflammatory measures to do that. So at the molecular or cellular level, the immune system does things to cause inflammation. It punches holes in cells, brings water in, brings in B cells and T cells and some of the innate immune cells, and causes inflammation. And unfortunately, it's not attacking a virus, it's attacking part of you. And the residual is that it causes brain and spinal cord damage, which damages the nervous system and causes things to short circuit. Let's switch to another question. Gleason, thank you for the flames. I'm super appreciative. Let's see what other, you know what I like to do is I'm gonna take a question that I had prepared ahead of time. And I'm gonna jump down here to a different scene. This is the river scene. I find it peaceful and relaxing. I hope that you do too. And let's take a question, see what we got here. All right, so this is a question prepared by Macy. Hi, Doc. Well, hello. Thanks for your content. You're welcome. I have a question about Kesimpta. Is it a good follow to Ocrevus? Or is it not suitable? Would Lemtrada be a better medicine in your opinion? So obviously, May, I don't have enough information to comment on your specific situation, but let's try to piece apart this question a little bit. The first part is, would Kesimpta be a good thing to follow up with after being on Ocrevus? And it really depends on why we're switching. So Kesimpta is a B cell depleter. It works by depleting your B cells. That's how it works. Ocrevus is also a B cell depleter. And so they both have the same mechanism of action. There's never been a Pepsi-Coke challenge, a side-by-side comparison of Ocrevus and Kesimpta. In my opinion, I think Ocrevus is probably a little bit better or more potent, more effective, but I cannot prove that with class 1 evidence. That's just my clinical opinion from using the medicines and from looking at the clinical trials. But I think that they're more similar than dissimilar. And so if you had MS disease activity on Ocrevus, I would not want to switch you to another drug in the same class. If I make up a stupid analogy, if you dislike Coca-Cola or it caused an allergy, I wouldn't switch to Pepsi-Cola because they're both colas. They're more similar than dissimilar. So if you had MS disease activity on Ocrevus, a new attack or new spots, I would not want to switch you from Ocrevus to Kesimpta. For that matter, I wouldn't want to switch you to Briumvi or rituximab for the same reasons, because they're all in the same class. What I would probably be doing is I would be looking for a drug with a different mechanism of action. And so you ask a question about Limtrada, that's a very different mechanism of action that would be on the table amongst many other drugs. Now, if instead you didn't tolerate Ocrevus, let's say, God forbid, that you had a very serious infusion reaction with Ocrevus. The drug was keeping your disease at bay, but you had a reaction and you couldn't tolerate Ocrevus. In that instance, going from Ocrevus to another B-cell depleter would be reasonable. That's not a bad move, because in that second example, you're responding to B-cell depletion, you're just having tolerability issues. So switching to a different medicine might be a decent option. And Macy, thank you for writing in that question. I super appreciate it. Let's take one more question that I've prepared ahead of time. So Mia Brickner, and I hope I didn't just butcher your name, Mia, asks a very, very reasonable question saying, what monitoring is necessary for Ocrevus? And so I would like to, actually, before I answer, everyone wave to Joe Siders, one of our amazing moderators. Joe, it is great to see you. I hope you and your family are doing well, and thank you for joining us. Don't worry about being late. We are delighted that you're here. Now, Joe, I was answering this question from Mia, who asked what monitoring is necessary for Ocrevus. And there's a couple things that we want to keep in mind. Now, interestingly, Ocrevus is not metabolized, okay? So it's not processed by your liver or kidneys. So it doesn't tax your liver or kidneys, which is pretty cool. It's catabolized, which is a funny word that means it dissolves in the bloodstream. So what we don't need to do is check liver and kidney labs like we do with a lot of other drugs. What do we need to do? Well, before we start Ocrevus, we need to make sure it's safe. And so in order to do that, we check some blood to make sure that you don't have latent hepatitis. We want to make sure that you mount an immune response to varicella, shingles, or chickenpox, and that's easily obtained by checking blood. We want to make sure that you don't have latent tuberculosis. The reason we want to check these things is we want to make darn sure that we aren't going to place your body at risk if we suppress your B cells, because those infections could come back out and cause a ruckus. I also like to check a couple blood labs before I get started, so I know your antibody levels and I know your lymphocyte counts and all these kind of important immunologic things before we get started on Ocrevus. I also think it's a best practice to make sure that we have an MRI of your brain before we start a drug, just so I know what we're getting ourselves into. Now, once you start Ocrevus, once you're taking Ocrevus, what do we need to be doing? One of the things that we want to be doing, in my opinion, is I want to get an MRI of your brain about once a year and an MRI of your spine at least once every couple years. Because one of the expectations for Ocrevus is that you don't have new MRI lesions. If you develop new MRI lesions on any drug, I'm not okay with that. And it suggests to me that the drug is not doing what we want it to. And so one of the monitoring to make sure that the drug is working is to check MRIs and compare them to the last year's MRI and make sure there are no new spots, make sure there's no enlarged spots, make sure there's no enhancing spots. That's one of the monitoring. Now, there's other monitoring for Ocrevus, and actually this is true for all of the B-cell depleting medicines that we've been talking about today, Ocrevus, Kesimpta, Briumvi, rituximab. You want to check the antibody levels. And so the doctor nerd word is IgG levels, immunoglobulin G. Those are actually your memory antibodies, and sometimes if you've been on any of these B-cell depleters for a period of time, the antibody levels can drop a bit. Now, dropping a bit is okay, but if it drops below 600, then we have to take pause and make sure that we're not significantly increasing your risk for infection. And so that's a lab that I like to check at the Boster Center for MS about twice a year, the IVIG level. I also like to check another lab called the absolute lymphocyte count. So this is a bit nerdy, and I apologize, but you got your blood counts, right? You got your white blood cell count. And then the white blood cells are made up of 5 different kinds of white blood cells: lymphocytes, monocytes, eosinophils, basophils. There's a bunch of different types of white blood cells. And the one that we're interested in is the lymphocytes. And so when we draw a lab, we can check a lymphocyte count. We can see the number. And again, I want to make sure that number hasn't gone too low. Interestingly, it's the same cutoff, 600. So if the lymphocyte count, the absolute lymphocyte count, is under 600, or the IgG is below 600, it doesn't mean that we have to stop a B-cell depleter. It does mean that we need to pay attention and make sure that we're not having increased risk of infection. So those are some of the things that I like to check when someone has started on a B-cell depleter, such as Ocrevus. Wowzers, there's 265 of you that have jumped online. That's amazing. Thank you for joining us today. This is an Ask Me Anything live stream, May edition, and I am delighted to be here with you with your questions at the ready. Let's switch things up, and I would like to take pause for a moment. I've prepared some things that I was hopeful I could share with you, and let's see. What we're going to do now is we're going to look at some MRIs together. And let's see here. I'm going to try. Yeah. So what I would like to do, and let's see if I can do this correctly. I'm going to throw up some MRIs. And I've removed all the names and the identifying information so nobody can figure out who exactly this patient is, because that would not be okay. And I want to use this scan to talk a little bit about how we monitor MS. And so what I'm showing you here on the left is a top-down view of the brain, all right? Now, the fancy term is axial, but it's really just a top-down view. And here you can see the person's eyeballs, and you can see their nose balls, and you can see their ear balls back here. Here's the back of their head. Now, the picture on the right is called a sagittal or side view. And this is the same MRI, the same human, 2 different angles. And here we see that we're chopping through where that yellow line is. So if you imagine, hypothetically, that we chopped this person's head off and then we looked down on top of their head, this is the picture that we would be looking at, okay? And so as you chop through their eyes, here we can see their eyeballs. And the reason I have this picture on the right set up for you is so that you can kind of get a sense of what level we're at. And so let's come down here, and I'm going to slowly walk through this with you and try to help you understand what I'm looking at. So here we can see their nose, and this is their sinuses. And if you look back here where the skull base is opened up, we see these gray structures. This is the cerebellum, all right? The cerebellum is Greek for the little brain. And what does the little brain do? It helps with coordination. If you have ever seen someone who was overserved and they maybe drank a little too much alcohol and they started to slur their speech or they started to stumble when they walked, that's because the alcohol has temporarily inhibited or turned off the cerebellum. And unfortunately, in the setting of MS, we don't need alcohol to do that. Sometimes people with MS can have damage. And I'm going to show you some cerebellar damage here in a second. I also want to point out this structure right here where my cursor is. You can see it right there. That's the medulla oblongata. Now, I'm going to date myself, but there's a really funny movie by Adam Sandler called Waterboy. And in Waterboy, they talk about the medulla oblongata, Colonel Sanders. And I think when they made that movie, they didn't know what the medulla oblongata was, but we do. It's that structure right there. So as we come up on the scan, and we see more of the brain uncovered here, we're looking at the cerebellum, the little brain in the back. I want to draw your attention to this spot right here. So you notice that there's this giant white spot, and that giant white spot is an MS lesion affecting the cerebellum on the right-hand side. And this person has unsteadiness when they move their right arm and when they move their right leg because of that lesion. Later, I'm going to show you a bit more about that lesion, so remember that one. Now, as we come up, we're seeing a lot of other structures. We have the eyeballs, we have the temporal lobes, and I want to direct your attention right here. Let me see if I can even move the cursor back a little bit. Do you see that white spot, guys? This white spot occurs in this structure, which happens to be called the middle cerebellar peduncle. There won't be a quiz, I promise. And it connects this structure called the pons to this part of the cerebellum. And that's on the other side of the cerebellum. So we have a lesion on the cerebellum that I showed you a little bit ago on the right. And now we have a lesion in the cerebellar connection on the left. So guess what? Nature's too generous. This person has cerebellar problems on both sides of their body because of those two lesions. As we keep coming up, we can see that that lesion is quite big, and you can see how it would interfere any connections between this part of the brain and that part of the brain. Now, here you notice that we're still at the level of their eyes, so we're kind of like chopping through right here, and you can see that level here on the yellow line. And I want to draw your attention right here. And you see that there's a white spot. And if you look carefully, you can see a tiny white spot over there. Those white spots, doctors call lesions. What is a lesion? It's code for brain damage. I don't want to sugarcoat things. I like to say them as they are. And that's what we're looking at here in the setting of multiple sclerosis. So at this level, we're just above the level of your eyes, like at the top of my glasses. And we can see there's some more white spots here. And as we come up, we're seeing yet more. There's one there. There's a big one right there. Now I'm going to come back to these spots later. This is a very important slice. If you see that little black structure, the black structure is the ventricle. The ventricles are a system of caverns inside the brain, and the spinal fluid flows through those caverns. Very commonly, we see MS lesions at the edge of the ventricles. Maybe some of you have heard the term periventricular. Peri means next to, ventricles, periventricular. And these are periventricular lesions, very, very common in the setting of multiple sclerosis. Now, as we come up, you can see that these lesions are not small. This person has a very significant burden of disease. Here we see this white lesion which stretches across this structure. This is a really big structure. You can see it right here and right over here. And on cross-section, it's this big thing over here. The big thing is called the corpus callosum, which in Latin means big body, and it connects the left side of the brain to the right side of the brain. So imagine that this part of the brain wanted to send a message to this part of the brain. How does it get there? It crosses the corpus callosum. And here, this person has grave difficulty in doing that because of a giant lesion, and you can see it on cross-section over there. So as we come up, you can see the full extent of that corpus callosal lesion. There's another lesion right there, and there's another white spot there. This is an important white spot. It's called juxtacortical. Now, I didn't make any of these terms up, guys. Juxtacortical is Latin for next to the cortex. So if you look with my cursor, see the white area on the edge of the outside of the brain? That is the cortex. That's the part of the brain which is the actual computer. That's what we use to think and do math and come up with language and sing songs. That's the part of that's actually the physical computer. Everything underneath over here, those are the wires that connect different parts of the computer. And when you see a white spot there, it's juxtacortical. It's right next to the cortex. It's another very, very common place for us to see multiple sclerosis. Now, as we come up, we can see that this person has very, very serious disease, and there's multiple periventricular lesions, there's multiple juxtacortical lesions. And you can see that these are very, very sizable lesions. The average size of an MS lesion is between typically 3 and 15 millimeters, and these are on the big side, guys. Now we're almost to the top of the head. Remember, if you look to the right, you can see where this line is, and that's where this picture is, and we're almost to the very, very top. Oh, Karen said you can't see my pointer. Gosh, that's going to make it hard. I didn't realize that you couldn't see the pointer. Thank you for bringing that up. Next time I do this, I'm going to have to come up with a better way of showing you the things. All right. Let me switch the picture, and I'm going to change it up and show you. Let's do this one. Now, what I've done here, guys, and I didn't realize that you couldn't see my cursor, and so I'll just do some talking. So on the left-hand side of the screen is the same picture that I showed you earlier. This is the top-down view where water is bright. If you look on the right-hand side, this is a different top-down view. This is after we give you the IV contrast dye. And what it allows us to do is it allows us to see where lesions enhance. Now, if you look at the bottom of the brain, you can see a white spot, in the cerebellum, and I thought that you could see my cursor, but now I know better. I'm so sorry. I'll figure that out for next time. And if you look on the right-hand side, you see that white area where those like kind of scary, it almost looks like the letter B. That is an enhancing lesion, which tells us that that lesion is brand spanking new. And so look at the bottom right-hand corner where it says axial GAD, and you can see that that lesion is enhancing. It means that it's a brand new lesion. It's only been there for a very short period of time. And if you look in the center of the screen, you can see a contrast enhancing lesion. This person, at the time the MRI was obtained, had very, very active disease. And as you look from left to right, you can see that some of the white spots on the left are enhancing on the right, but not all of them. Here we see another very, very large enhancing lesion that you can see on the right. I didn't realize that you guys couldn't see my cursor. Sorry. So let's just spend a few more minutes and go through the scan. I wanted to share with you what an active MRI looks like and share a little bit about how we go through MRIs together. I'm not exactly sure that was a successful attempt, guys. I didn't realize you couldn't see my cursor. Thank you for putting up with me. Let's switch things up. Enough of that. We've got some calm waves, and this is a great time to kick off the MS Water Challenge. So you know how this works. When I drink, you drink. I've got my seltzer water here. Drink up, guys. MS Water Challenge, I love it. This is super good stuff. Seltzer water from Roger. All right, now, so Marianne says, I'm not sure Dr. Boster's right is our right. That's because the person in the scanner is upside down. And so what you're seeing on the right is your left as you look on at them. Let's take a couple other questions coming from the live stream. I'm going to scroll back and try to find a question that was asked while I was babbling about MRIs. So here's a question from Christina. It says, what's the biggest size lesion that you've ever seen? So there's a term in MS called tumefactive lesions. So a tumor, like from cancer, has an appearance on the MRI. They're typically really big and scary, and they've got a lot of swelling around them. And there are some MS lesions that are tumefactive, which means they're not a tumor, but they sure as heck look like a tumor. And those tumefactive lesions can be gigantic. I've seen tumefactive lesions that take up a quarter of the top of the brain. Very, very scary looking. Something which is really interesting, in a good way, is that tumefactive lesions generally do not have a very bad outcome. You would think because they're so big that they're really, really bad, but not always. And so that's a very interesting phenomenon. Okay, all right, you guys were being super helpful in trying to tell me, we can't see your cursor, we can't see your cursor. And I'm going to figure that out for next time. All right, let's take another question. Let's see. So KJ Burke just said, Dr. Gavin Giovannoni said just 2 days ago that people with multiple sclerosis have a 5 to 10 year reduction in life expectancy and more than 50% of their life expectancy reduced by more. You just said the opposite. Now I'm confused. Well, so first of all, Dr. Gavin Giovannoni I consider to be a work friend. He is a remarkably wonderful MS researcher and MS neurologist out of the UK. He's at Bart's MS. He has a beautiful presence on the internet, helping to educate, energize, and empower families impacted by MS. And you can find him on Twitter. He has something called the MS Selfie, which is probably where this information was written. So when you look at multiple sclerosis historically, people impacted by MS could die 5 to 7 years earlier than the general population. In the modern era, however, I think with the earliest applications of high efficacy medicines and attention to symptomatic management, we can change that. And it's my strong opinion that through those measures, the average person with MS can expect a normal life expectancy. Now, does that make him wrong and me right? No, but that's my interpretation of the data. I have tremendous respect for Dr. Giovannoni. He's a great guy. I've learned a lot from him over the years, and I think it's awesome that you're following him on social media. All right, let's see here. Other questions, guys? Show me your questions and I'll answer them. While I'm waiting for a question to pop up, let's take a question about my favorite topic, sex. So this is a question from Brad, who said, I have a question I'd like to ask you regarding impotence in sexual activity and whether there's any research going on for multiple sclerosis. Yes. So unfortunately, when the brain or spinal cord is affected in the setting of MS, you can have difficulties with what I call the down theres. So I refer to the down theres to reference bowel, bladder, and bedroom. And in the setting of multiple sclerosis, bedroom problems can occur. If you are bothered by words like lubrication, orgasm, vagina, and penis, you should log off the live stream immediately because I'm going to say those words. So difficulties can occur in arousal or interest in sex for many different reasons. Difficulties can occur with lubrication in a woman or erectile function in a man, which is what this question's a bit about. And there can be difficulties in achieving orgasm. Now, in my experience doing MS neurology for basically 20 years, if you would like to make an adult human really miserable, mess with their down theres. Develop a problem with bowel, bladder, or sexual function, and you will find someone who's really sad, blue, and depressed. Now, the good news is oftentimes this is treatable. And because Brad is asking about impotence and sexual activity, let's focus for a few minutes on male sexual function. And oftentimes, a gentleman can develop difficulties with obtaining and maintaining an erection. And there's a host of things that we can do. I always like to start by looking at medications to make sure that we're not on medicines which can impair that, because that can happen. And if we're on some medicines like that, we want to take them off. I also am very keen on checking a gentleman's testosterone levels. So testosterone is the male secondary sex hormone, and low levels of testosterone can cause problems with the down theres. And so I think checking a testosterone level is a very important idea. We want to do a morning draw, and we want to do 2 of them. And if they're low, typically below 250, then that would suggest that we have some testosterone deficiency, and we could explore testosterone replacement therapy to help that guy out. Now, a real quick comment about that. Testosterone replacement therapy doesn't just help with the bedroom. In the setting of MS, it helps with cognition and it slows disability, which is crazy important and all too often missed. Now, what else can be done if a gentleman is having erectile dysfunction? We can try a pill. And so many of you have heard of sildenafil, which is Cialis, or excuse me, that's Viagra. Cialis is another brand of medicine which can help significantly with erectile function. Sometimes that doesn't work, and we can get a little bit more serious. I will ask a patient, how much do you care? And if they care a whole bunch, we can send them to the urologist. And there are old school medicines, which are actually an injection in the side of the glans penis. They are very, very effective. And many guys just went, ugh, they don't want to inject themselves, but depending on how serious they are about desire to obtain an erection, they can. Now, I have some patients where measuring testosterone, changing medicines, taking Viagra, even those injections don't work. And in those cases, we can send them to the friendly neighborhood urologist and have a penile implant. I have several of my patients that have gone as far as to have penile implants, and every single one of them thinks it's the best thing they've ever done, and their partners feel the same. And so this is an important part of life. I don't want you to shy away from it. I certainly don't want you to be embarrassed about it. And I do want you to talk to your provider to say, hey, what can I do about my sexual dysfunction? And if the neurologist is a little skittish, say, okay, doc, that's fine. Why don't you send me to a urologist or someone that's not skittish and they can help me out? I'm glad that person asked that question. Tell the Truth asks about IVIG. I assume you're asking about IVIG. So IVIG is a very expensive medicine. It's given intravenously in the vein, and it's pooling a bunch of antibodies. So let me explain. When someone donates blood, we separate the red and the white. All right, so we separate everything out. The red blood cells are used to help when someone loses blood and needs to have oxygen carrying capacity. But the other stuff is cleaned up, and we extract the antibodies. And we actually pool the antibodies from thousands upon thousands of donors. We put it all in a bag together. We clean it so there's no hepatitis or HIV contamination. And you can infuse intravenous immunoglobulin, IVIG, into someone's arm. Now, this has been studied in MS, and I believe that IVIG works to treat MS. But the data is not robust enough that it's oftentimes covered by third-party payers, and it's very expensive, and that can create significant challenges. I will share that I have used it several times to help patients when almost nothing else has worked. Also, remember when we were talking about monitoring B-cell depleters earlier, like labs you check for Ocrevus or Kesimpta or Briumvi or rituximab? If we find that the antibody levels are low and there's an increased risk of infection, we can do something clever. We can keep the medicine going and we can give them IVIG in addition, and we can boost those antibody levels back up. That treats a really funny word, hypogammaglobulinemia, and I did not make that word up. It's not even a good Scrabble word because I think it's longer than 11 letters, but it means that your antibody levels are low. Great question. Now, Pataskala-Chick 5 asks a great question, and I'm wondering if Pataskala-Chick 5 lives on the east side of Columbus. Pataskala is a town that I know very, very well. Asks, how much Adderall is too much Adderall? Well, first of all, what is Adderall? Adderall is an amphetamine salt. So Adderall is a medicine which is used oftentimes amongst preteens and teenagers who have something called attention deficit disorder, or ADHD, attention deficit hyperactive disorder. And fascinating, when you give a child with ADD Adderall, it stimulates their brain adequately and it allows them to focus. So that's really interesting, right? If you gave someone without ADHD Adderall, they'd be hyper and bouncing off the walls. But when you give a child that has ADHD Adderall, it actually allows them to focus better. I'll give you a quick example about my sibling who struggled in school despite working very, very hard every night, super frustrated, a lot of tears, a lot of tutors, nothing was working, diagnosed with ADHD, put on Adderall, straight A's ever since, really, really changed things and allowed her to do outstanding. Now, in the setting of multiple sclerosis, Adderall is a very powerful and helpful symptomatic tool. It's a symptomatic drug. What I mean by that is it doesn't slow MS down. So taking Adderall or not taking Adderall is not going to change the long-term course of MS. But it can treat two very, very important symptoms, which are common: cog fog and fatigue. The leading cause of loss of work in multiple sclerosis is not inability to walk. That's not why people lose their employment. It's because they can't think clearly, because they're either profoundly exhausted despite sleeping, or they have cognitive fog and they cannot attend. They cannot lock onto a task at work or at home. It makes it hard to learn new things and to work under time pressure. It turns out that when you take an amphetamine salt, like Adderall or Ritalin or Focalin or Vyvanse or any of these medicines, it helps in a way somewhat similar to ADHD, and it allows the person with MS to be more awake so they can function, and allows them to be more attentive so that they can do well in their job and at home. And I'll give you an example of a gentleman that I take care of who's the partner in a big law firm. He's been a partner for a long time, and he started to have increasing difficulty with work performance. He was literally falling asleep at his desk. He couldn't read through a brief, and the other partners were discussing literally voting him off the island. Pretty serious stuff. We put him on Adderall, and he's never looked back. It's been about 10 years now, and he's crushing it. Pretty cool. Now, the question was, how much Adderall is too much Adderall? And that really gets into a couple things. Number one, side effects. So when you take Adderall, it can cause an elevation in your blood pressure, which can be dangerous if it goes too high. And so we need to monitor blood pressure. We need to make sure that it's not going too high, because that would increase your risk of stroke or heart attack, which are bad. It also can cause some other things with your heart. It can make your heart beat too fast or rarely beat irregular. And so we need to check that out. It also can cause some side effects such as irritability. It can cause insomnia. It can cause headaches, and it can cause what's called bruxism. So bruxism is a doctor word for grinding your teeth. And I've actually had patients that have broken teeth because they've bitten so hard when they're sleeping at night. And so obviously all drugs have side effects, and Adderall is no exception. Also, Adderall can cause a tolerance, meaning as you take Adderall for a while, you start to get kind of used to it, and then you need a higher dose in order to see a benefit, and a higher dose to see more of a benefit. And again, you increase the risk of high blood pressure, et cetera, et cetera. Now, one of the ways that we can say too much is too much is if you have those side effects. 1 second while we do a little MS water challenge. You know what to do. When I drink, you drink. Drink up, guys. Ah, that's good. Woo! All right. So, a couple things that we want to think about Adderall. If we have cardiovascular risk factors, we want to check with your cardiologist or we want to check with your primary care to make sure that it's safe to give you Adderall. We also want to make sure that you're on the lowest dose which is effective. So oftentimes when I'm treating an adult human with Adderall, I'll start them off on 5 or 10 milligrams when they wake up, and we might dose again at noon if we need to. I'm going to drop some knowledge on you now, a trick, a tip, a helpful tool which helps keep Adderall working, and keeps it safe. It's called a drug holiday. When I give people Adderall, I ask them to take 1 or 2 days off every week. Because if they don't take 1 or 2 days off every week, then the drug starts to tolerize and it doesn't work as well. But if they have a lazy Sunday or a lazy Wednesday or what have you, and they take a break, when they come back to it, it works much, much better. And that way they don't tolerize to it. Adderall is a helpful tool. It helps a lot of my patients. And I'm really glad that you asked that question. Now, at the end of the day, too much Adderall is something that you and your neurologist are going to have to figure out specifically for you. That was a great question. So Erica asks a follow-up question. She says, well, why would a neurologist decide not to prescribe Adderall when someone has cog fog? And there may be a couple different reasons. So for example, if there is a risk of cardiovascular stuff, they might not feel comfortable doing it. Also, Adderall is a controlled substance, and some doctors are a little bit hesitant to prescribe controlled substances. If someone had a history of difficulty with drug and alcohol use, there may be reasons why they're not comfortable giving Adderall. And some doctors are nervous Nellies, and they just don't feel comfortable with things like Adderall. So what do you do in that instance? One thing you could do is say, okay, doc, I understand that you're not comfortable, but I'm the one suffering from cog fog. I'm the one suffering from fatigue. Could you please refer me to someone like a psychiatrist that might have more comfort in trying to prescribe Adderall? That was a great question. Let's try to find another question. And before we do that, let's change up the scene. Woohoo! So here's my tablet scene. I'm amazed that there's 273 of you that have jumped online. Thank you very, very much. Let's take a live question as I look through here and try to find one. Mike asks about the tau patch. And Mike, I think the tau patch is a bunch of crap. I think it's a scam, and I would not recommend using it. That's my opinion. Alexis asks a question, piggybacking off our earlier conversation about Adderall. Alexis says, is Adderall or modafinil better for MS, idiopathic hypersomnia? All right, so let's pick apart that. Hypersomnia means super sleepy, so that's a way of saying fatigued. Idiopathic means we don't have a reason why. Well, if the person has MS, it's not idiopathic in my opinion, it's caused by the multiple sclerosis. And so basically, Alexis is saying, if you have fatigue from MS, which drug's better? And I think it depends on the individual. We've talked a little bit about Adderall. That's an amphetamine salt, which can help with fatigue in MS and cog fog in MS. Modafinil, which goes by the trade name Provigil here in the United States, or its cousin R-modafinil, which goes by the trade name Nuvigil, is a different central acting stimulant. And it doesn't work the same as Adderall, but it's a very, very effective drug. And I like to prescribe modafinil instead of Adderall if I can. Why? Well, here in the United States, I can prescribe a 3-month prescription of modafinil, so you can get a 90-day supply. Whereas in the Adderall, I can only do 1 month at a time. And so it's more cumbersome to prescribe Adderall, and it's more challenging. The patient has to go to the pharmacy way more often. I also find that the tolerability with modafinil might be a bit better. Now, when it comes down to brass tacks, every human is a little bit different. And I have some patients where Adderall worked way better for them. I have other patients where modafinil worked way better for them. And so, unfortunately, there's a little bit of trial and error trying to figure out which is going to be the best. All right, let's take another question. That was a really good one. Thank you for asking it. Looking through, trying to find a great question. While I wait for questions to pop up, I'll take another prefab question, but of course I'm going to change up the scene. This is a funny scene. I like this scene a lot. some people, they throw a little shade when I throw the seat up, and they think it's too flashy. So tell me what you think in the comments if you find this wall and mirror to be silly or not. So here's a question comparing drugs, and this is a question asking, is Kesimpta or Mavenclad better? And we don't know. There's never been a head-to-head comparison of Kesimpta or Mavenclad. My opinion is that in groups of people, Kesimpta, a B-cell depleter, might be a more effective drug. But I said might be because I can't prove that. And I wouldn't look at someone who wanted to take Mavenclad and say, oh, that's a terrible drug. I think all things being equal, they're both really, really good. But in my biased opinion, I would put Kesimpta a notch above Mavenclad, particularly in its ability to slow disease progression. That's just my 2 cents. Well, Aaron Gill says that the wall's adorable. Thank you very much, Miss Gill. I really appreciate you saying that. Melissa likes the scene too. Thank you. All right. Let's take a look at another question. So here's a question from Carolyn who says, could you answer about yeast infections with Ocrevus? All right, so Ocrevus is a B-cell depleter. It works by suppressing a sliver of your immune system. This is the same way that we help with Briumvi, with rituximab, and Kesimpta. They're all B-cell depleters, and they all suppress the immune system a little. When you suppress the immune system, you can increase the risk of infections, and that can include yeast infections. Now, I wouldn't say that it's very, very common, but excuse me, I have plenty of patients on an immunosuppressant, and they may develop thrush, which is a yeast infection in their mouth or throat, or they can get vaginal candidiasis, which is a fancy way of saying yeast in the down theirs. Now, the good news is we can knock that out with a pill. I give people a pill called Diflucan, and they swallow it, and that's like a nuclear bomb for yeast. Blow it up, and they feel better. Or we can use creams, and there's even over-the-counter creams that you can use on the down theirs to help with that. Here's a favorite question of mine from Luca, who says, what about Ampera and erectile dysfunction? And so again, if you're squeamish talking about penises, leave the live stream immediately, because I'm going to say penis a few times. Penis, penis, penis. So sometimes a gentleman with MS has erectile dysfunction because of heat-induced problems. And that's a bummer because oftentimes during intercourse, you raise your core body temperature, and you can literally like short circuit, and then you can have a heat-induced erectile dysfunction. And I've seen this a few times in my career. When you take the medicine Ampera, it buttresses against heat sensitivity. So sometimes people, when they get overheated, their leg becomes weak. Sometimes when they get overheated, they lose vision in an eye. Sometimes when they get overheated, they can have erectile dysfunction. And in those situations, I've had really awesome success using Ampera to help with erectile dysfunction. I'll never forget the first time I discovered this. I was seeing a patient, and he was with his wife, and they were in the room. And as we were wrapping up, literally hand on the doorknob, she says, oh, Dr. B, I forgot to tell you something. You may never remove my husband's Ampera. And I said, okay. And she said, I don't think you heard me. You can never remove my husband's Ampera. And I said, what? And she explained that when he developed MS, he developed very significant erectile dysfunction. And he had had erectile dysfunction with interfered with intimacy for years and years and years until we started him on Ampera. And her quote was, he's 18 again. Now, he's still on Ampera, and they're still very happy, and that's an awesome story. Ben has just joined us, one of our amazing moderators. Thank you very much. Here's a question from Michelle, who writes, is there a medication for incontinence? And the answer is yes. There's a lot of medications for incontinence. So the medication depends on the type of incontinence. Incontinence is a doctor word for I peed my pants. So why did you pee your pants? There's really two different kinds of problems with MS bladder. Sometimes you have a little racquetball bladder. There's a spasm of the bladder, and it's like a tiny little racquetball, and you can barely hold half a soda before you start to have to go to the bathroom. And then you develop symptoms of overactive bladder. This is things that you see like frequency, where you're getting up every 15 minutes to go potty, or urgency, oh my God, I gotta go right now, or incontinence because you can't make it in time. Now, when you have that kind of problem from overactive bladder, there's a bunch of awesome medicines that can help. So Myrbetriq, Sanctura, Ditropan, Detrol, these are all pills that you take once a day, which can help relax the bladder to a normal size so that you have normal carrying capacity. You can finish drinking your seltzer water, wait till the end of the live stream, and then go potty. And that's awesome. That's not always the only problem that you can see with MS bladder. There's a different problem that you can see with MS bladder. So the bladder then has a tube called the urethra that goes out to the toilet. And that urethra can clamp down really, really tight, right? So you're trying to push urine through it. It's like trying to push urine through a swizzle straw, and it's really hard to do. And when that happens, there's a different kind of problem. It's called retention, where you feel like you need to pee and then you can't get it out, or it's really hard to start peeing, or the stream is not strong like when you were younger, or you can't empty all the way, and you think you're done peeing and you stand up and then you have to sit right back down and go more. And sometimes the bladder will fill and fill and fill, and it's under significant pressure, and then whoosh, all the water comes out, and you can have an incontinence from that problem, which is really, really unpleasant. Oftentimes, that person doesn't know that they're going to have an accident. So it's not like overactive bladder. They're just doing their groove thing, and then they lose all their water. Yuck. And to treat that incontinence problem, there's a different set of medicines. And those medicines don't work on the bag, the bladder itself. They work on the urethra. Tamsulosin, which is Flomax, is a medication that I use a lot of times. And there's other ones that can be used like Cardura. Now, these are all kind of awesome things to talk to your neurologist about. And again, if your neurologist says, I don't know, well, that's okay. Ask to go see a urologist. These are great questions. I'm super appreciative that you guys are here. I also can't believe that there's 270 folks that have jumped online today. This has been the Ask Me Anything May live stream. My name's Aaron Boster, representing the Boster Center for Multiple Sclerosis. And as always, thank you for joining me. If you haven't yet, take a hot second and click the link down in the chat box. That'll sign you up for the Boster Corner, which is a monthly newsletter where we put out the latest and greatest, all the things that are going on at the Boster Center for MS, all the research that we have going on, all the opportunities that we have, and it gives you information about when I will be going live next. I am going to continue to do a live stream, typically the last Saturday of every month, and this will conclude our May live stream. As always, thank you for learning about MS with me. It is my goal to energize, to empower, and educate families impacted by MS, and I want to thank you for taking some time out of your Saturday. So until I see you the next time, this is Aaron Boster saying be safe